My name is Dr. Veronica Ajewole. I am an associate professor of pharmacy practice at Texas Southern University, and I am a clinical pharmacist in oncology at Houston Methodist Hospital. Prostate cancer is one of those cancers where oral chemotherapy is being used. So I do see a good number of patients that have prostate cancer. What I'm trying to highlight here is that not only are African American men diagnosed with prostate cancer, when they are diagnosed with prostate cancer, they are diagnosed with a more aggressive type of prostate cancer. Racism plays a factor in almost every facet of the continuum of care for cancer. And when I speak of continuum of care, I'm talking of prevention. The idea behind prevention here and screening also is what is the level of health literacy that makes a patient comfortable to say they want to go and get their screening done. And unfortunately, when we now look at the underrepresented minority population, access to care is one of the barriers. The patient screens early, on time screening. Average risk patients start screening at the recommended age. There is a likelihood that if the patient would develop cancer, the cancer could be detected at a lower stage. The ripple effect of racism then leads to that fact that, a patient would not present to the clinic for PSA check, for prostate health check until the patient becomes symptomatic. Until now, they're having urinary urgency, they are urinating blood, all the symptoms that comes along with prostate cancer diagnosis. So even though it might not be a direct construct, but there is that ripple effect of racism, annual physical is recommended for every patient, right? But when we look at the ripple effect of racism, right, like I said, African American, low economic status, limited access to healthcare, probably does not even see the PCP. They never saw the four walls of the clinic until they became symptomatic and they were in the emergency room, and boom, prostate cancer diagnosis. The absence of, number one, having that access to seeing a physician in itself just for routine annual physical checkup, there is already a big limitation on the level of awareness that the patient knows or what they should have known about prostate cancer. The extent of the physician-patient relationship helps to build trust. And in the absence of having that trust, some of these conversations might not even come up during a physical, during a visit to the physician, for example. Or sometimes even if it comes up, it might just, you go to the doctor, they tell you so many things, right? How many of those things actually sticks in the memory of the patient? Not much. So that's another factor. And then on the part of the physician as a clinician, there is the ethics part of clinical practice that should tell a clinician to share information with the patient regardless of, orientation, any form of bias. We should put aside our own implicit bias. We should put aside our own, premonition and share information with patients. Because of the disparity in health literacy between non-Hispanic whites and non-Hispanic Blacks, I sometimes have my, non-Hispanic white patients come to me with a printout of a clinical trial, believe it or not. That happens to me in clinic. So at that point, when I see a patient coming to me in that light, my discussion level with them is different because I know, the level of education or literacy of this person is at this level, and that's how I'm going to approach the discussion. Versus maybe a Black patient who does not know so much, and they are pretty vulnerable to the information that you share with them, to the information that you offer them in African American patients. It's more of a question of, is this going to work for me?